For the aorta, you simply have to have the IVC in the optimal longitudinal plane and then tilt the transducer more to the left side of the patient, where you would expect, of course, the aorta. Here you have the aorta seen in this image. It's normal in size. You have the celiac trunk, the superior mesenteric artery, here the liver, the right atrium seen as well. So depending which transducer you use and which exam you perform, the orientation can be upside down as well. So it's very important to differentiate abdominal ultrasound from echocardiography. As said, here we have more anatomical findings, the celiac trunk, the superior mesenteric artery, as mentioned before. And continuing, of course, we want to see some pathologies. In this case, you have a severe pathology. You see that there is a membrane. So you have two echo-free spaces. You have here the mesenteric artery, here the superior mesenteric artery, the celiac trunk. And when you utilize color Doppler, you do see you have here two overall possibly blood-filled structures. So this is a case of aortic dissection. You see that the aorta is definitely enlarged. Here you have this dissection membrane. This is the true lumen, the false lumen, and there is shunting in between the true lumen and the false lumen. You also see that there is turbulent flow towards the celiac trunk as well in this view. So to summarize, from this subcostal approach, very often you get a very good glimpse of the aorta, and you should always at least once take a look at the abdominal aorta as well. For the IVC, I want to add one information, because sometimes it's not that easy to see the IVC in this longitudinal plane. You are not entirely sure where you are actually located. Then simply use also a transverse plane. So rotate the transducer that you have a transverse plane and see if the IVC is round and not collapsing, or if it's oval shaped or more ovally shaped and collapsing nicely. So they can also get a lot of ideas and more knowledge of what the IVC is actually showing you by means of volume status, by means of atrial pressures, right atrial pressures in this case. There are some special views I want to talk about, not only the possibility to look at the short axis from a subcostal approach, but also a long axis view. So when you over-rotate and the marker points to the right shoulder, so not like in the four-chamber view to the left of the patient in the short axis to the left shoulder, or the marker pointing towards the heads cranially for the IVC or the aorta, you really want to rotate the transducer until the marker points to the right shoulder. And here you have the same structures as in the peristernal long axis. Again, this view you can use when the peristernal view is simply not possible, or if you need additional information. In this case, you see the tricuspid valve almost, again here in this view, you see all the three cusps. So it's still a little bit off axis, but it's a splendid view of the tricuspid valve. The right ventricle, the left ventricle, here you see parts of the mitral valve, and the ascending aorta you can visualize here, the aortic root and of course the aortic valve opening quite nicely in this case. So already here you can see that there is definitely no aortic stenosis present. So by means of subcostal approaches, it's very important to know that most of the views you can find peristernally and also apically are possible to be visualized in these subcostal views. In the subcostal long axis, of course, you can also use color Doppler, and in this color Doppler study you see that there is mild aortic regurgitation present. So again, we do not see real turbulent flow when the blood is exiting the heart, so the LVOT, the aortic valve. You simply see that the valve is opening nicely, but there's trivial aortic regurgitation present. You can even tilt a little bit more and then you can get more views. So in this case, we have here the tricuspid valve with all the three cusps. We initially see that there's the aortic valve and even larger parts of the ascending aorta. And when you even tilt more cranially, so the transducer pointing cranially, you see the RVOT from this atypical subcostal approach, where you see the long axis view of our heart.